Welcome to the deep dive. Today we're tackling a pretty specific topic in veterinary medicine, leiomyosarcoma, or LMS, in dogs and cats.
That's right. We've got some sources that really dig into this uncommon cancer. It affects the smooth muscle and their gastrointestinal systems.
Yeah, the stomach, the small intestine, large intestine, all that.
Exactly. So our goal today is to unpack what LMS actually is, how you might see it presenting in pets, the
This
signs,
diagnose?
how it gets diagnosed, right?
Yeah.
And then treatments, and what the outlook, the prognosis usually look like.
It sounds complex, and interestingly, something our sources point out right away is how our understanding is, well, evolving.
Oh, definitely. A lot of tumors that maybe years ago were just called LMS are now being identified as something else. GITESTs, gastrointestinal stromal tumors, or GST-like tumors.
And you need specific tests to tell the difference.
Precisely. It really shows how, the science doesn't stand still.
So just for clarity, while we know about this GESTS distinction, we'll mostly stick to the term LMS today following our source material.
Yes, exactly. For consistency with the sources, we'll use LMS, but it's crucial for you, the listener, to keep that nuance in mind. That distinction between true LMS and GIs is really important clinically.
Okay, got it. So let's start at the beginning. What exactly is leiomyosarcoma? Define it for us.
Okay, so LMS, it's an uncommon malignant tumor. That means it's cancer.
Yeah.
And it originates from the smooth muscle cells lining the GI tract.
Stomach, intestines.
Right. And the key thing about it is its behavior. It tends to be locally invasive.
Meaning it grows into the tissues right next to it.
Exactly. It doesn't always stay nicely contained.
And invasion isn't the only worry, is it? What about spreading metastasis?
That's the other major concern. Our sources say up to 50% of these can metastasize.
Half. Wow. Where does it typically spread?
Often it stays within the abdomen. Common sites are the abdominal lymph nodes and liver.
Which obviously impacts the outlook. You mentioned the prognosis is often described as, what was it?
Fair to guarded. That potential for spread really influences that assessment.
And you mentioned the large intestine. Is there a specific spot there that's more commonly affected?
Yes, the cecum, that little pouch off the large intestine, seems to be a common site for LMS development.
Okay. And just to circle back to that GIST point, telling them apart needs special testing.
Correct. Immunohistochemistry, often looking for a protein called c-KIT, is usually needed to definitively say if it's a true LMS or a GIST or GIST-like tumor. It's not something you can always tell just by looking at basic cell structure.
That really underscores the need for detailed diagnostics. Okay, let's talk about who gets this. Is it more dogs, more cats, any age group?
The sources suggest dogs are more commonly affected than cats.
Okay.
And typically we're looking at middle-aged to older animals, so generally over 6 years old for both dogs and cats.
Any particular breeds popping up more often?
Interestingly, no. It doesn't seem to have a specific breed predisposition.
All right, so older dogs mainly, but cats too, any breed. Now, what about signs? What might an owner actually see at home?
Well, it really varies depending on where the tumor is located.
Makes sense.
If it's in the stomach, the classic signs are things like vomiting, maybe weight loss.
Okay. And the small intestine?
Similar signs there, like vomiting and weight loss too. But you might also see diarrhea, maybe borborygmus.
That rumbling sound?
Yeah, the gurgling in the belly, and sometimes even increased flatulence.
Right. And then the large intestine, or the rectum, sounds like different signs again.
Completely different, yes.
Yeah.
There you might see tenesmus that's straining to defecate.
Which could even lead to rectal prolapse sometime.
It can, yes. And owners might also notice hematochezia.
Blood in the stool.
Fresh, red blood in the stool, exactly.
Those are quite distinct location-based symptoms. Now, what about when the vet examines the animal? What might they find?
Again, it depends. With stomach LMS, the physical exam findings can be pretty nonspecific. Not much to go on sometimes. But if the tumor's in the small intestine, the vet might actually feel a mass in the middle of the abdomen.
Palpation.
Or sometimes they might feel bowel loops that seem distended, maybe painful when touched.
And lower down. Large intestine, rectum.
In those cases, yeah, a mass might be palpable during a rectal exam.
So the physical exam gives clues, but it sounds like it's not always definitive, especially maybe early on or with stomach tumors.
That's fair to say.
What about the cause? Do we know why this happens? Any known risk factors?
Sadly, no. Our current understanding, based on these sources, is that the exact causes, the risk factors, they're basically unknown.
That's frustrating. Common theme with cancer, unfortunately.
It is. It highlights where more research is really needed.
Okay, so given the varied signs, sometimes vague exam findings, and the unknown cause, how does the diagnostic process usually unfold? What are vets trying to rule out?
It's definitely a process of elimination sometimes. The list of differentials, other things it could be, is pretty long. Oh, things like a foreign body stuck somewhere, inflammatory bowel disease, even parasites. Then you have other tumors like adenocarcinoma, leiomyoma, the benign version, plus the GI we mentioned, lymphoma.
Even pancreatitis?
Even pancreatitis can sometimes mimic the signs. So
Yeah.
yeah, it really emphasizes why you need a thorough workup. You can't just jump to conclusions.
Absolutely. So, what are the first steps usually? Basic lab work, blood tests, urine tests.
Right. Initial tests like a CBC biochemistry panel and urinalysis are standard. Often they actually come back normal.
Oh, really? Not very helpful then.
Not always directly helpful for diagnosing LMS itself, but they're important for ruling out other issues and checking the pet's overall health. Sometimes, though, you might see abnormalities.
Right.
Well, you might find anemia, sometimes a specific type, like iron deficiency anemia, perhaps from chronic blood loss.
Okay.
You might see leukocytosis, which is a high white blood cell count, maybe indicating inflammation or stress, and less commonly, hypoglycemia, low blood sugar. That's mentioned as a possible paraneoplastic syndrome with LMS.
So, the cancer itself causing low blood sugar, not directly from the tumor's location.
Exactly. It's a systemic effect of the cancer. But again, that's less common.
So, basic labs might give hints, but aren't the definitive answer? What about looking inside? Imaging, ultrasound, x-rays.
Imaging is definitely key. Abdominal ultrasound is often very useful. It can show a thickened area in the stomach or bowel wall, which is suspicious for a mass.
So you can actually see the thickening.
Yes. And then for x-rays, you might use contrast material. For the stomach and small intestine, a positive contrast study where the pet swallows barium or something similar can highlight a mass that's taking up space.
Okay.
And for the large intestine and rectum, a double contrast study, using both air and contrast material, can achieve a similar result, outlining any masses there.
So imaging helps visualize something is wrong, but getting that definite diagnosis sounds like we need tissue.
Precisely. That's the gold standard. If ultrasound shows a mass or thickening, you might start with a fine needle aspirate, an FNA.
Just sticking a needle in to get some cells.
Right. And cytology, looking at those cells under a microscope, might show malignant mesenchymal cells, which points towards a sarcoma, like LMS. You can also do FNA on enlarged lymph nodes to check for metastasis.
But is FNA always enough for a final diagnosis?
Often not definitive for type of sarcoma, but suggestive. For a definitive diagnosis, and especially to differentiate LMS from GIS, you usually need more tissue, a biopsy.
And how do you get that? Things like endoscopy.
Endoscopy, using a camera scope, is an option for the upper GI tract. You can see the lining and take small mucosal biopsies.
But you mentioned earlier the tumor might be duper.
Exactly. That's the problem. LMS can often be submucosal, meaning it's under the surface layer that the endoscope can easily reach. So those small superficial biopsies might just grab normal overlying tissue and be non-diagnostic.
Ah, so you might miss it.
You might miss it or get a misleading result. Because of that, a surgical biopsy, actually going in surgically to get a larger piece of the tumor, is often required for confirmation.
And similar issues with colonoscopy for the large intestine.
Very similar. You might see a bulge or mass with the colonoscope, but again, if you just biopsy the surface mucosa, it might look normal even if the tumor's underneath. So deeper biopsies are better if possible, but often surgery is needed for the definitive sample there too.
So surgery plays a dual role then, both for diagnosis and potentially as the main treatment.
Absolutely. Surgical resection, removing the tumor, is the cornerstone of treatment for LMS.
Okay. And you mentioned earlier that cecal LMS seems to have a lower chance of spreading.
Yes, that's an interesting finding from the sources. Cecal location seems somewhat protective against metastasis compared to other spots.
And surgery can really make a difference in survival time.
Ooh, significantly. Especially for small intestinal masses, successful surgery can lead to much longer survival times.
But before doing a major surgery, you'd want to check for spread, right?
Critically important. You need to stage the patient. Check those common metastatic sites like abdominal lymph nodes, the liver, even the lungs via chest x-rays before undertaking a potentially extensive and costly surgery.
Makes total sense. What about other treatments? Chemo, radiation. Are they used much for LMS?
For true LMS, our sources don't emphasize chemotherapy or radiation as primary treatments. The focus is really on surgery.
But what about that JACE distinction we keep mentioning? Does that change the treatment plan?
It absolutely can. This is where the immunohistochemistry, checking for that c-KIT protein, becomes really practical.
How so?
Well, if the tumor is positive for t-KIT, meaning it's likely a GIST or GIST-like, then targeted therapy with drugs called tyrosine kinase inhibitors might be an option. Tosiranab phosphate is one example mentioned.
So drugs that specifically target that c-KIT pathway.
Exactly. It's a form of targeted chemotherapy, often used as follow-up after surgery, or sometimes if surgery isn't possible. So that reclassification isn't just academic, it can open up a whole different therapeutic avenue.
That's a really important link. Okay, so after treatment, what's the typical follow-up and what does the prognosis generally look like long-term?
Well, we know LMS likes to metastasize, often to the liver and abdominal lymph nodes. Older studies gave some survival stats. They varied quite a bit by location.
What did they find?
For small intestinal LMS, the median survival was around 12 months. For cecal cases, it was reported as 7.5 months. But there was a catch. Many of those dogs apparently died from other unrelated causes.
Okay. And stomach LMS?
That was noted as being rarer, but with a high metastasis rate and generally shorter survival times.
But you also mentioned something encouraging, even with metastasis.
Yes. Interestingly, one study found that even dogs with metastatic GI LMS could sometimes have prolonged survival, reporting a median of almost 22 months. So it's not always an immediate death sentence, even if it has spread.
That's quite a range. What about more recent data? Does it paint a different picture?
More recent studies looking at dogs treated surgically for a mix of these tumor types, LMS, leiomyoma, GIST, GS-like, show maybe slightly more optimistic trends, especially depending on location. For small intestinal tumors, the 1-year survival rate was around 63% and 2-year survival about 52%.
So over half alive at 2 years.
Right. But for cecal tumors, the numbers were even better. 1-year survival around 84% and 2-year survival at 66%.
Wow, that's quite a difference for the cecum. Location really matters.
It seemed to dramatically impact long-term outcome, yes. Cecal tumors definitely seem to have a better prognosis overall based on that data.
So if surgery is successful and the tumor is completely removed, what's the recommended follow-up?
The standard recommendation is regular checkups. This includes a physical exam, chest x-rays to monitor the lungs for any late metastasis, and abdominal ultrasound to check the surgery site and other abdominal organs.
How often?
Typically, these checks are advised at 1, 3, 6, 9, and 12 months after the surgery. Keep a close eye during that first year.
And what if the surgery couldn't get all the tumor? Incomplete resection.
Yeah, if margins are dirty, meaning some tumor was left behind, or if the tumor simply couldn't be fully removed, the focus unfortunately shifts more towards palliative care. Managing symptoms, keeping the pet comfortable, maintaining quality of life for as long as possible.
That really brings home the challenge of dealing with this, especially if it's caught late or is very invasive.
It does. Early detection and complete surgical removal offer the best chance.
Okay, this has been incredibly informative, a real deep dive into LMS. So summing up, it's a rare, malignant, smooth muscle tumor in the GI tract of dogs and cats.
Right. Signs vary a lot by location.
Diagnosis requires careful workup, often imaging, and frequently surgical biopsy to confirm and rule out GIST.
Which is crucial because that GIST classification might open up targeted drug therapies.
And surgery is the main treatment, with survival times varying, but definitely better chances with complete removal, especially for those cecal tumors.
That covers the key points well. It's a disease with some unpredictability, influenced by location, metastasis, and that potential reclassification.
Definitely. Which leads us to a final thought for you, the listener. Given these challenges, the difficulty in early diagnosis, the potential for spread, the evolving classifications, what do you think are the most promising future directions? Where should research focus to improve early detection and treatment for these kinds of aggressive cancers in our pets? Something to think about.
A great question to end on. Thanks for joining us for this deep dive.